So this is the second part. We'll be now talking about the subcostal suprasternal view, and we'll address a bit ductal assessment. So um, you have access on the web on the slide, so you'll be able to review. So one of the view of the subcostal, so first of all, the subcostal view is a very good view because it has a tendency to use the power of the liver to be so you put the probe close to the liver and you're angulating towards the left chest because that's typically the area that the heart would be, although in babies it has a tendency sometimes to go towards the central area of the chest. But it's a really good view, first of all, to assess the situs of the patient to make sure that you're not missing an heterotaxic syndrome. So you want to see the actual IVC on the right and aorta on the left of the body, and you want to see the actual IVC connecting to the right atrium. And ideally you want to do this in the two views, so in the cross-sectional view and in the longitudinal view. So you actually want to sweep and see the IVC in the subcostal cross-sectional view as you sweep entering the right atrium, and then you want to do the same thing in the longitudinal axis, so that you don't mistaken like azygous continuation or subhepatic veins or things like that for an inferior vena cava. So typically the subcostal view is something that's useful also to obtain some of the Dopplers of the descending aorta, as well as the superior mesenteric artery and celiac artery. It's also a great view when you don't have great thoracic views. Why? Because you can think of babies who have bronchopulmonary dysplasia or lung disease, and they get a lot of residual pulmonary artifact, or even babies that have the heart that is just under the sternum or in the back of the chest, or our cardiac colleagues will sometimes face patients will have open chest, like the sternum is open, so they cannot really go nicely on the chest unless they use like very sterile probes and sterile gels. And even so, you want to try to avoid going on fresh wounds. So subcostal view sometimes is the best view you're going to get to obtain the assessment of the heart function, that you're going to be able to see the outflow tract. Like you can see here, you can see the RV outflow tract. You're able to obtain some information about the output. You're able to see the IVC, the SVC. You can see sometimes some of the valves. You can also assess the configuration of the septal geometry. So sometimes it's the only view where you're going to be able to assess the left ventricular configuration relative to the right ventricular configuration. And it's also a great view to see if there's pericardial effusion and for line placement. So really in subcostal, you can get a lot of information. The problem with subcostal is that in babies, it's often an area that they don't like us to play with at the beginning. So they typically, as you're doing your echo, it's typically going to be one of the last views you're going to obtain, because by that time, the baby is used to have the gentle pressure on their body and feels like comfortable. So by the time you get closer to the belly, they've kind of got prepared, versus if you just start and you put your probe on the belly, often the baby will tense up and it becomes more difficult to obtain images. Sometimes also in some of the babies who have a lot of like aerophagia from non-invasive ventilation, it may be a bit more difficult to obtain some of these views. So we can do both short axis, where you're going to be able also to assess the presence of an interatrial shunt. Actually, you can do that in short or long axis. And the short axis, actually it's written short, but it's a long axis view. Sorry about that. This is a long axis view of because you see it's RV and it's LV along the long axis. And it's a great view to see the outflow tract of the right ventricle. It's a great view to see the tripartite RV. So the RV has typically three parts. It has the inflow, the body, and the outflow tract. And really, with only one sweep, you're able to assess all these parts of the right ventricle. And sometimes it's one of the great views to obtain an assessment of right ventricular function. Although a lot of the metrics that we have to measure right ventricular function are not adapted to the subcostal view. You can also do a 3D acquisition in subcostal. You can actually obtain a 3D volume from subcostal because they're very, very echogenic. It's just that then when you put them in most of the commercial software to reconstruct the 3D volume, they're not adapted to the subcostal. So there's a bit more manipulation to try to reconstruct the actual volume of the right or the left ventricle. And you can also see coronary sinus. It's also a view that if you don't have any other views to visualize well the interventricular septum, you can put color over it. And during the subcostal sweep, you're able to see if there's actually a connection or not. So really a view that has like a lot of potential. So that's an example of a situs view where we see the aorta, the spine, and the inferior vena cava. And you can see that the aorta is on the left side and the IVC is on the right side and and the liver is here, which corresponds to the right side of the patient. So this is when we do the actual sweep where we see the actual connection to the right atrium. Eventually, we see the superior vena cava. This is the right ventricular body and outflow tract. So, and you can see here that there's a foraminal valley. As you sweep, so if I go like section by section, so we have liver here, and eventually you see here your IVC. And as your IVC, you follow the connection, you see that it connects to your right atrium. So that's the kind of sweep we want to see. And then we see our interauricular or interatrial septum, where we have the right atrium and the left atrium. And you can see that there's the flap of the PFO here. And you can see that it stretches a bit, probably that there's a left to right shunt undergoing, which stretches the flap. And then you get to see a bit of the right ventricular inflow portion, and you see the left ventricle. And as you sweep, you start seeing your papillary muscle of your left ventricle, and you even see your outflow tract of your left ventricle, and you can see the valve open and close. So it's a good view also to assess that your LV to outflow tract is well open and that there's no obstruction. So you can think of a baby infant of diabetic mother who has maybe septal hypertrophy or biventricular hypertrophy and has also terrible lungs because of asphyxia, because the baby was born at 5.5 kilo and then there's like a meconium aspiration syndrome, and it becomes very difficult to image the heart. This is a good view to assess the outflow tract and making sure that you have output. But you can see how the angle here of insonation is, more pronounced than you would get in apical 5 chamber view. So to get an actual Doppler of the outflow tract, you can underestimate the actual VTI or the velocity time integral. But sometimes this is the only view, so you can try to align yourself as much as possible by moving your probe in the subcostal region if there's no other area that you're able to visualize nicely the outflow tract. Here we see, sorry, it moved too quickly. Here we see the SVC, the superior vena cava. And as we go along, we can see actually nicely the view of the ascending aorta. So you could even measure technically your ascending aorta. Although this is not the classical view that is validated with Z-scores. And then we start seeing more of the body of the right ventricle. So you see this is the tricuspid valve. You can even see some of the attachments that are going to the septum. And then you see the RV outflow tract. So this is the body of the RV, and then you have the outflow tract portion of the RV. And that's a clear view. And you even see the moderator band in some of these views, these tissue here. So moderator band is one of the key elements that dictates if a right ventricle is a right ventricle on the right side. Then you want to do the same by color. So here, same thing, we're doing the sweep, and this time we see the SVC flow. So you can see that the Nyquist has been decreased a bit in order to see more of the venous flow and to see if there's an interatrial shunt. So as we sweep, we kind of see a bit the flap of the PFO. And here you see a bit of the red going through. So it tells you there's a left to right shunt through that PFO, which is minimal. And again, and now you see the SVC flow coming into the right atrium. So it's a good view also to look at the position, for example, of cannulas, and here to see if there's, line into the right atrium. And obviously, when I see a line in the right atrium, just one view is not sufficient because sometimes you can have image of composition. So you need to confirm this in multiple views to make sure that you're really into the right atrium and it's not just a superimposition view. So I often say, if you're looking for position of a line that's too deep, it's better to confirm with two views before saying, oh yeah, the line is too deep, because sometimes we can get fooled by ultrasound. And what we want to make sure is that there's no PFO. Ballpark from the literature, 4 millimeter. 4 millimeter and up is considered something that needs follow-up in terms of interatrial shunt. Obviously, when you have a preemie that's 24 weeks, 23 weeks, 400 gram, the initial scan where they could have an ESD, it's going to be much smaller than 4 millimeter because their heart is smaller. But by the time you are at term, if you're 4 millimeter and more, probably you need a follow-up in the outpatient setting. And the bigger, 7 millimeter, of course, you need a follow-up. But that's the kind of borderline in terms of what's benign and what's more something to follow. So here is when we're doing the color over the septum and the outflow tract. And you can see here at the end of the scan, as you're getting towards more anteriorly, if we hadn't put color, we wouldn't have noticed that there's this restrictive jet here, which is a muscular VSD. Very benign VSD that probably will close on its own in due time, but it's something that, first of all, is very useful to Doppler, because if you Doppler it, you get an assessment between the gradient of the LV and the RV, which informs you in systole about pressure gradient into the outflow tracts. So it's a good way, easy way to rapidly see and screen if there's signs of pulmonary hypertension, right? Because if you have a gradient through a VSD that tells you the gradient is, I don't know, 65 millimeters of mercury, and your systemic blood pressure is 85, well, you know the systolic pulmonary arterial pressure is like 20, 15 to 20. So that's really an easy, you don't need a TR jet and spend hours to try to get one. Not hours, obviously, but it's quick, easy, and you get the information. And also this patient, if it has a murmur, that's the reason of the murmur. It's going to be a systolic murmur because it's very restrictive. So it creates turbulence and acoustic findings. And the last thing is that this patient needs a follow-up to make sure it closes in due time. Okay, so you can see it. And it's only, and you can see how interior you have to go. This is a very interior view, cross-sectional view. You can also do what we call the TED view, or the inflow outflow tract view of the RV in the subcostal area, if you're not able to get it in the apical view, where you see the tricuspid valve, you can actually see the inflow, and then you see the body of the RV, and you see the outflow tract of the RV. This is one of the perfect view to make sure that there's no obstruction of the RV outflow tract and that there's good continuity and the valve is opening. And why is this view important? It's one of the view that they use in cardiology to assess the tetralogy of Fallot to make sure that there's no signs of pulmonary stenosis or RV outflow tract obstruction or or infundibulary obstruction under the RV outflow tract. Here we see the posterior portion of the right ventricle and the anterior portion of the right ventricle. So you're able to assess, but we're losing, you can see that we're losing a bit of the view. So probably would have to move a bit to see it more nicely. And we can actually see the IVC connecting to the right atrium. And to get this view, it's almost like getting a 2-chamber view, but drawn into the subcostal area. So really the probe, kind of directing towards the clavicula, because you want to see the posterior and you want to see the anterior, right? So you're kind of cross-secting your body like this. Okay, this is a sweep. I think we already saw that sweep. So in this view, what we can do, we can measure, this is one of the techniques to measure the SVC diameter. At our lab, we don't technically, or we don't necessarily use very commonly the SVC flow as a marker of, clinical significance of any kind of physiology, because it tends to be very variable how you measure it. Like, where do you measure it? Do you measure it here? Do you measure it here? Do you measure it higher? One of the techniques described in Australia, there's a few articles, and I don't have an example here, is by using an M mode in a modified parasternal view on the SVC. and then measuring like, 3 times the SVC and then doing an average of that. But other publications have looked at just the junction between the RA to the SVC and doing the diameter there. So that's another example to measure the SVC diameter in this particular view. Okay, and another example. So we see the right atrium, we see the SVC, and then we can measure it. Personally, I like this view to see the presence of a line, okay, in like a PICC line if it's too deep. It's also an interesting view if you're suspecting that there might be an AV malformation of the brain, because then you're going to see a lot of torrential flow and the SVC is going to start to dilate. So you're going to see like a lot of flow at very high Nyquist, very high velocity filter. So if you're suspecting a vein of Galen, this is definitely a view you want to see. You can also see the SVC in the suprasternal area. We're going to be looking at that. The Dopplers can be obtained from either the short axis view or the long axis view. You want to be aligned with your SVC as much as possible. And then you want to trace throughout one cardiac cycle the VTI of that SVC. So here I'm tracing the VTI and obtain the stroke distance of my SVC. So I'm able to eventually, the same way I've calculated the LVO, the RVO, you plug the diameter of the SVC and then you plug the VTI and then you obtain an assessment of their SVC output. So that's live. That's an example. You have here a bicaval view where we see kind of the IVC. It looks like a Mickey Mouse, like the ears and then the face, So you have the SVC flow here. And you can see some red and blue, which tells you that in this particular clip, there is retrograde flow at some point in the cardiac cycle, which is normal to sometimes have some degree of retrograde flow in the SVC or the IVC, but you don't want to spend more than 50% of your time in retrograde flow. We see sometimes retrograde flow during contractions of the right atrium, especially if there's a bit of increased right atrial diastolic pressure, or if there's a Steele effect or things like that, you can see sometimes brief retrograde flow into your SVC. This is kind of similar to when we see the flow retrograde into the pulmonary veins. So if you have right atrial kind of increased pressure, you may see the volume or the duration you spend in retrograde starts increasing. So that's an indirect sign of the right ventricular diastolic pressures. Obviously, that's true if you don't have a atrial shunt that decompresses your right atrium, or if you don't have like a high pressure for some reason in your abdomen or in your brain that's preventing this retrograde flow from happening in the context of right ventricular and diastolic failure. So here you can see the flow, and I'm tracing the flow. So you can see my little yellow line kind of tracing, and then you get the VTI, which would give you kind of a assessment of stroke distance in the SVC. Very similar again. That's just an example to exemplify. And you often see kind of these biphasic and triphasic waves that we see with venous flow and venous return, which correspond to the different kind of cycles that you would see in the cath lab, basically, on pressure loops. So bicaval view with color. You can see that in the bicaval view, if I put color, my color box is almost perpendicular to the flow in the IVC, which is here. And then one thing that I often see people is that they press very hard on the belly to try to see the IVC, and they don't see the IVC. And the reason is that it's a venous pressure that collapses very easily. So as soon as you put a bit of pressure, it's going to collapse. So often, I tell people, like, if you don't see the IVC, it might be that you're putting so much pressure that you're collapsing the IVC. So make sure to remove a bit of pressure to see if you see your IVC or not. The importance of seeing the IVC is that, you want to make sure, first of all, that there is one. Second of all, it allows you to visualize if there's a line or not in the IVC. And it also is a good view that we use sometimes, to get the indirect assessment of what's happening in the right atrium. So if it looks very juicy or dilated, it might be that your right atrial pressure is a bit higher. It might be that your filling is good, or it could be because you're in RV failure, or it could be because you're mechanically ventilated. So that's why, using the IVC diameter in the neonate to assess volume status is a bit tricky, Because if they're intubated and ventilated, your IVC might look completely normal, and it doesn't mean that your baby's not dehydrated. Or it might be a big IVC, but it could be because you're in pulmonary hypertension and your RV is struggling. And because of that, your right atrial pressure is high and then your IVC starts dilating. So it doesn't mean that it's dilating, that you're in fluid overload. So you have to be careful about how you interpret, and then sometimes it has to be a combination of many things. Um, uh, you know, to describe if there's underfilling or not. Often underfilling is not so easy to actually tell from echo. It's really extreme cases of dehydration that are often kind of noted because the body is very good at trying to preserve its intravascular status and especially its intracardiac status. Now, obviously, if you're in the emergency room and you see kids arriving with like severe gastroenteritis using point of care ultrasound, it's much easier to look at the IVC under spontaneous breathing, and then it's a better assessment of volume status. But in babies, there's so many other things that are happening, like high PVR, RV hypertrophy, intubation, ventilation, even non-invasive ventilation, like sometimes can increase a bit the afterload. So all these things have to be taken into account when you're using these markers. This is a view where you can also visualize the interatrial septum between the right atrium and the left atrium. And so it's a view where you can also see, okay, do I have a sign of PFO and flow? Now, that being said, in this particular view, you can see that the velocity of filter is very high. And if you're trying to visualize if there's a flow coming from one atrium to another at a very low velocity, you might not pick it up at this high filter velocity. Okay. So in this view, you can also measure the SVC diameter. So we see here the SVC, we see here kind of the IVC, and we see some of the subhepatic vein that are starting to drain into the IVC. And the subhepatic vein, you can see, is much more in line with your color box and your probe than the IVC, which is almost perpendicular. So whenever we Doppler what's reaching the right atrium as a marker of impeded flow to the right atrium, we typically will Doppler the subhepatic veins more than the IVC to see if there's like retrograde flow. So if you're concerned that there might be right ventricular diastolic failure, that the RV is not able to fill, and because of that, your right atrial pressure becomes high, one of the indirect kind of assessment is to Doppler this. And if you spend a prolonged period of time in retrograde flow, like more than 50% of the time, it's typically abnormal. So in BPD pulmonary hypertension, for example, it's something, if we see or if we're concerned of pulmonary hypertension, it's somewhere that we're going to want to go and Doppler. If you're not concerned of hypertension, the RV looks beautiful, it's slim, the TR is normal, you have a full curve, it's not necessary to go and Doppler because we're more focused. So same thing in short axis, we can do a sweep. And in this sweep, you can see that the LV is very round relative to the RV that's crescentic. So that's a good view. If you're not able to assess the septal curve in the parasternal short axis, you can see here nicely that it's a very circular structure and that the RV is much slimmer. As I'm going back, you can see, so first you see the SVC to RV junction to RA junction, sorry, SVC RA junction. This is the view, by the way, to rule out sinus venosus defect. So sinus venosus defect are one of the pulmonary veins will unroof into the SVC. So basically, instead of draining to the left atrium, the course of the pulmonary vein actually opens up into superior vena cava, and that acts like an ASD. It acts like a significant left to right shunt. And so these patients in long term, if they're missed, they can develop, like anything that's related to ASD. So RV volume overload and eventually remodeling of their pulmonary vasculature, volume loading. And in the long term, they can get pulmonary hypertension in the age of 30, 40 if you don't pick it up. So this is the view where you would see actually that there's a connection between one of your pulmonary veins and the SVC. So it's something to pay attention when you scan these patients to not miss. So we see the SVC, the kind of portion of the IVC getting into the right atrium. We can see the tricuspid valve here. We can see the left atrium in the background. And as we're advancing, we see what? We see a PFO with the flap of the PFO. You see that flap? It's here. This is the flap. And as I'm going slowly, you see the flap going up and down. And so there is presumably a connection between your left atrium and your right atrium. You see more of your tricuspid valve. And you start seeing more of your right ventricle. And eventually, you see in the background your ascending aorta, and you start seeing the valve of the aortic valve. So here, you see the aortic valve. You see more of the body of the right ventricle, and eventually it's going to give rise to the RV outflow tract. So you remember it's a tripartite ventricle. And now you can see kind of the pulmonary valve and the RV outflow tract. Great view for looking at the areas of the infundibulum of the RVOT and making sure that there's no obstruction. So acceleration of flow or absence of flow or pulmonary atresia. So, but here we can even see the left pulmonary artery and then the right pulmonary artery branching, right? The two branches, it looks like a Y or like a peace sign. And we can see nicely the valve open and close. And I don't know if you can appreciate, but the RV outflow tract and the aorta, they're kind of going in perpendicular direction, which is basically the normal configuration, because if they were parallel, you would suspect a transposition of great arteries. The other thing is that the pulmonary valve and pulmonary artery is a bigger diameter than the aortic valve and the aorta. So here now we're at the level of the papillary muscles. So just before that, we saw kind of the mitral valve, almost this fish mouth, right? And then we see the two papillary muscles as we go down. And what you want to do is ideally go up to the apex, because we know the apex is a very contractile element of the left ventricle. And it's also a zone where you could have buried like VSD that are missed in other views. So it's a good view to actually scan and make sure you don't miss a VSD. And then here, this is with, relatively no Nyquist. And look at that. We can see that there's a VSD towards the end. So first of all, we see the blood flow going to the RV outflow tract. And then at the end, we can kind of see this flow here that is coming from a VSD that we saw in the other view. And you see it here. You can see it here. And because my Nyquist is low, there's a lot of aliasing. So it's very tough to say what's the directionality. It is left to right, but because it's left to right, because we saw it from other views. But when you have very low Nyquist, sometimes you can, you have to be careful about the interpretation of color flow when there's turbulence. So here, as I'm going back, I see the nice flow from the RVOT through the valve. You always have to make sure that the flow originated below the valve, because if you had a PDA, you could have swirling and you could miss that there's pulmonary stenosis or obstruction of the RV outflow tract. Same thing, we even see the flow going through the aortic valve as we're scanning, you see. And then as I'm getting closer to here, we can even see that there's the PFO, but it's hard to visualize kind of the flow through it, probably because we're not aligned, we're kind of on the side of it. We even see the spine. We see the spine here, which is a good view to move your probe and try to see the aorta, which we kind of visualize here. This is the aorta. So you have the whole aorta here, and we get a bit of the flow. And that's the actual angle you want, because the aorta is going this way and your probe is going this way. So that's the most aligned you're going to get, because if you're more like this, you're going to be perpendicular. So ideally, you want to have the aorta the most longitudinal in order to do a pulse wave Doppler in your descending postductal aorta. So in the subcostal view, you want your aorta to be as longitudinal as possible to avoid being in a situation where you're too perpendicular to the probe, and then your pulse wave Doppler is not very good. So the assessment of atrial shunt, it provides you a lot of information. So this is an example of left to right shunt. So you see it's red, it's going from the left to the right. Here you can see that it's blue and red. So it means it's bidirectional, it's going on both sides. And here it's completely blue, it's right to left. When you see this, what is the one thing you absolutely need to rule out if you see this. There's a one, you see that the first thing, there should be a reflex in your mind that should be, ooh, I need to rule out this. Absolutely.
Anomalous venous
You mean
return?
pulmonary hypertension?
Total anomalous pulmonary venous return. If you see a right to left shunt at your ASD level, your first reaction should not be, this is pulmonary hypertension. Your first reaction should be, I need to rule out total anomalous pulmonary venous return. Why? Because TAPVR drains into the right atrium through various channels, either via the coronary sinus, via infradiaphragmatic connection to IVC, or eventually even SVC connection, so through cardinal veins. So there's multiple configuration it could drain. But the one thing it's going to end up doing is a right to left shunt at the ASD level. Why? Because all the systemic venous return and all the pulmonary venous return comes to the right atrium, and nothing comes back to the left atrium. So it's completely empty. So it's an obligatory right to left shunt at the atrial level. So you absolutely need to rule out TAPVR. That's the first reaction. When you see a right to left shunt at your PFO, not bidirectional, a strict right to left shunt, you need to rule out this. Then once it's ruled out and you're like, okay, this is not TAPVR, then you can look for other reason. Is it a vein of Galen? Is it an IVC arteriovenous malformation that's bringing tons of blood flow to my right atrium? Is it that I have pulmonary hypertension and because of that I have RV failure? Now, I'll be honest with you, to get a fully right to left shunt at PFO level, it's typically that your RV is really struggling, or that your acute pulmonary hypertension is very, very severe. Because typically it's going to be more of a bidirectional shunt most of the time. Because what happens is that your right and left atrial pressure are similar at some point in the cardiac cycle, so you get a bit of bidirectionality. But if you see a strict right to left shunt, it's typically that really you're unloading a significant portion of right atrial to left atrial shunt. The other thing it could be pulmonary atresia. It could be pulmonary stenosis. It could be tricuspid atresia. So you could have nowhere for the RA to empty. So many of the cardiac defects could be with a strict right to left shunt, right? Like pulmonary atresia intact septum. If there's no VSD, if it's an intact septum, well, the flow has nowhere to go. So for sure, it's going to go through right to left at the ASD level. If you have tricuspid atresia, for sure, it's going to be right to left. If you have pulmonary stenosis, well, maybe it's going to be bidirectional if there's still flow going through your outflow tract. Or if you have a pulmonary atresia, but you have a VSD that can decompress your right ventricle. So yes, with severe pulmonary hypertension and RV diastolic dysfunction, you get increased RV and diastolic pressures, and this could be bidirectional, eventually right to left shunt. And the volume that it shunts will make you desaturated pre and postductally. But obviously your preductal reflects often what's happening at your atrial or ventricular level. And then your postductal reflects what happens in the postductal area, right? So you could be desaturated to the 80% in acute PH, for example, because you have a lot of blood flow that is deoxygenated and entering the systemic circulation via the atrium, often because on top of it, the atrium is underfilled because there's not a lot of pulmonary blood flow and there's not a lot of pulmonary venous flow coming back. We can see in this view, actually, in the background, the aortic flow. So you can see the pulsation of the aorta here. So that's another example of left to right shunt, bidirectional shunt. And then here in 2D, you can actually even visualize a sweep and you can see kind of your PFO presence. So that's when it's frozen. So sometimes it's good to just freeze it to make sure, am I missing a right or a left? Like what's the exact directionality, especially if it's very brief in the cardiac cycle. The other thing sometimes you can do is just by Dopplering. If you put a pulse wave Doppler, you can see, is there a component of right to left? Right? Because you're going to see it, it's going to go into the negative range. And sometimes you can use M mode color. So you put the color, you put your line of M mode through the PFO, and then you look at the color on it. But I think one of the best ways is actually the Doppler because it really provides you with the velocities. And this is how we would measure it. Ideally, so here, I took a clip with a color, which is not good practice. You want to actually measure it in 2D, in the bidimensional, and you want to measure it at its largest diameter. Okay, so I would sweep and I would look, and sometimes the septum may have multiple ASD. So you're going to measure the largest one, but you may want to measure other, portion of the wall that might be with a hole. So here, we can see the ASD here. So we would measure it. So that's example of subcostal view where we see the catheter. So this is a catheter in SVC. So you can see nicely the catheter in the SVC at the junction with the right atrium. Here you can see a PICC line coming through the IVC, but actually entering your right atrium. So it's slightly a bit deep. So we would probably pull it out. This is the spine, and this is the aorta, and this is, you can see the double line of your umbilical arterial line catheter. You can even see kind of the diaphragm coming here. And then the last view is a catheter in the IVC, which is also kind of floating a bit into the right atrium. So these are good views to check that. So suprasternal view, I'm going to let you review some of the schematics, but you can see the SVC, you can see the RPA, the LA. These are good views, for example, for even the PDA sometimes is a good view to obtain for the arch, for making sure that the arch is a left-sided arch, that there's no signs of vascular rings. So cardiology will use that a lot if they are screening for vascular rings. It's also a good view to assess for coarctation. And for line placement, sometimes it's the view you're going to get. So this is the aortic arch. We have the ascending, transverse, and then descending, and we have the isthmus, which is a zone of connection with the PDA. And then often there's a proximal and then there's a distal transverse arch, which typically the proximal will be between the first and the second vessel, and then the distal will be the second and the third vessel. So this is the distal and this is the proximal here. The ascending is kind of in this area. Great view if you put color to make sure that there's no, because you're very aligned with the aortic valve. So when you scan patient with like aortic stenosis, this is the view you go to get the gradient of the aortic stenosis, because that's where you're the most aligned. So you would do a CW in this view, because that's where you pick up the acceleration. This is also the great view to look at the arch and making sure that you don't have any sign of posterior shelf. Posterior shelf would appear like a little triangle here, and it would really narrow the arch. Okay, and you can really see it nicely when the PDA closes, actually. When the PDA is big, it's very hard sometimes to notice because the tissue surrounding the posterior shelf will have a tendency to constrict at the moment that the PDA constricts. So if the PDA is wide open, the tightening around the coarctation is not there. So sometimes you can miss it. And that's why sometimes we wait for the PDA to close to really saturate if there's a coarct or not. At least in cardiology, that's what they do. So here we can see the flow. So you can get pulse wave Doppler in the preductal and postductal, but you can also do a CW through the actual descending arch to make sure that there's no acceleration or sign of obstruction and that there's no gradient above 15 or 20 millimeters of mercury through the arch. Okay. So you see nicely that the flow looks laminar. So again, this is the visualization. So we have the ascending, we have the transverse, and then we have the descending. You have your brachiocephalic arterial trunk, which will divide eventually into the right subclavian, right common carotid artery. Then you have the left common carotid artery, and you have the left subclavian artery. Sometimes when these two have also a base that is combined together, we call it like some people call it the bovine arch. Because it has these two trunks, but it's a bit of a misnomer because when you look at the arteries of bovines, they don't have this configuration. So it's not true. It's not really a bovine arch because it's not like this, the bovine arch. But it's been in the kind of nomenclature that people use for some reason. So we like to say, brachiocephalic arterial trunk and then common origin of the left common carotid and left subclavian artery. That's what you should be saying if you see that these two vessels are kind of combined together at its origin. The other thing is that it's a good view. Sometimes when they have a combination of both, it will look a bit more narrow. So sometimes it can look like a hypoplastic arch. So you have to be careful to follow these patients if you suspect that. or eventually, of course, have cardiology assess these patients if you're concerned about a hypoplastic arch. And there are Z-scores to put for the arch that's been published to make sure that the arch is not too small, if you suspect that the arch is too small. And then in the middle, you can see the right pulmonary artery, and then in the background, you can see the left atrium. So you would put the flow here, and ideally you would have a pulse wave Doppler in your descending aorta from this view because you're very aligned. So if you're looking for retrograde aortic flow, that's a good view to do that. So that's an example of a normal arch where we see very laminar flow, very nicely open arch up to the descending. We can see the right pulmonary artery. You can see kind of the three vessels. So you want to be in line with these three vessels, ideally. You can even see on top, what's this organ? What's this?
Thymus.
This is the thymus. Yes, exactly. So thymus is good to know that you have a thymus. It doesn't rule out DeGeorge anomalies, but if you have it, it's a good sign. Versus if you don't have it, then it points towards a DeGeorge if you have also like a cardiac defect. But you can have DeGeorge and a thymus, so you have to be careful. And it doesn't mean your thymus functions. Sometimes the thymus is dysfunctional in DeGeorge, even if you have one. So that's an example of a coarctation. We can kind of see the narrowing, the very narrowing, and you can see the turbulence. You can even see it here, the narrowing as you're going down, and then your PDA kind of feeding inside the descending aorta to provide flow to the descending aorta. And then as you scan this patient, you can see that there's like tissue in the background, right? It looks like almost like a finger dangling into the aorta. And that's this posterior shelf that's causing kind of the obstruction and blockage, right? You can see it's almost touching each other, like if someone is pinching the aorta. You can see like this is very narrow here, versus if you compare it to this ascending aorta, which is a much more bigger caliber. So ascending, sometimes the transverse is difficult to see. So that, where's the branching of the vessel? That's probably the distal transverse. The proximal is probably here because I think the first vessel is around this area. And then you have the descending aorta, you have the postductal and the preductal. And then, often the preductal, or you could, many places you'll call it the isthmus of the aorta. So you can do Doppler, pulse wave Doppler in your ascending aorta. So here you have a peak systolic velocity. You can do also a VTI of the whole tracing. Sometimes you can do the VTI of only the systolic tracing. So it depends, what you're looking for. And then here you can see that I'm Dopplering in my descending aorta, and I have anterograde systolic flow and then retrograde flow throughout the diastolic phase. So before my next systolic wave. So this is like kind of a steal phenomenon. That's an example from the suprasternal region where you can again see retrograde flow. And then this is from the actual subcostal region. So you have the spine here, you have the aorta, you have the pulse wave Doppler, and you can see that there's consistent holodiastolic retrograde flow, sorry. So this is your differential diagnosis of the holodiastolic retrograde aortic flow. There's not just the PDA that's left to right that can cause a steal. You have to think of things like arterial trunk or truncus arteriosus, or other variants, like for example, a right pulmonary artery that comes off from the aorta. Well, there's going to be a steal when the PVR starts dropping. Aortoventricular tunnel. So that's like what it says. It's a tunnel between the aorta and the ventricle. You can have an AP window. So some patients may have a connection between the aorta and the pulmonary artery. That's not the PDA. It's just a defect from the two vessels being connected. Patients with BT shunts can have that because there's a steal right through the BT shunt. Vein of Galen malformation can have like a big steal into their brain or any kind of AVMs of the brain. And typically they'll have also torrential SVC flow versus the hepatic hemangiomas and hepatic AV malformations. They're not going to have a steal from their aorta typically because it's much more deeper, the connection to the liver. It connects to the celiac trunk. So you might not pick up this retrograde flow into the descending postductal aorta. And typically they have IVC flow that's increased. It's not SVC flow that's increased. Makes sense? Significant aortic valvular insufficiency. So if you have like severe aortic insufficiency, you can get retrograde flow. If you have aortopulmonary collaterals that are significant, you can get retrograde flow. And sometimes in HIE, they have so much cerebral autoregulation anomalies and they get like this severe cerebral vasodilation, especially if they're seizing and they got a lot of like anti-seizure medication. Their artery starts dilating a lot because of these medication, but also because their underlying disease. And sometimes you'll see retrograde flow with no PDA and nothing else. And that's just because they have like steel into their brain. It could be, I wonder sometimes, is it like a, safety mechanism to provide more perfusion to the brain, like, favoring the flow going to the brain even in diastole? I have no clue. But I can tell you that we see it clinically. So you can also see the SVC flow. This is a short axis of your suprasternal view. So here you have the SVC flow that's here, and you can actually see your aorta. This is the branching of the aorta that's coming, and we're following these vessels of the aorta to see that it branches on the right side. So you saw those two vessels, it branched towards the SVC. So as we're trying to sweep towards the right side of the body, there should be branching of the brachiocephalic trunk if you have a left arch. So if I go back and you follow these red pulsation, you can see suddenly that this vessel is gonna boom, divide into 1 and 2. Same thing, this vessel eventually divides in these two vessels. So vessel dividing into the two vessels here. You can even see here that the SVC is here, and you can see the innominate vein which connects the left arm to the SVC. So just for the last minute, because I'm gonna have to close this this session. This is a crab view, very low Nyquist, very low velocity. We have here the left atrium, and we can see the 4 veins, 1 and 2, 1 and 2, draining into your atrium. This is a very high view in the suprasternum, and it's very anterior. So you get to see your 4 veins, and then so 1, 2, 3, 4, and then from this view, you can Doppler at the ostium, these 4 veins, to make sure that you're not missing any kind of stenosis. So you want to see a biphasic or triphasic type of Doppler spectral profile with very low velocities, so below the 40 centimeters per second, 50 centimeters per second. You can see a triphasic, biphasic with high velocities when you have, for example, overcirculation or left to right PDA, but you should always have this biphasic, triphasic pattern. It shouldn't be like a pattern that's like, with no phases. Because if you lose these phases, it's a sign that there might be turbulence and that your ostium or stenos, which you can see in patients, for example, post-op, or that you can see in patients that had, for example, lines, and then your lines are too deep, and then they start trickling the ostium of the veins, and then the vein starts fibrosing. Or you can see in BPD pulmonary hypertension. In some of these babies, they can develop multivenous disease for some reason. We're not sure why some of these patients develop that. There's multiple theories. Here, this is a patient with transposition of great arteries that we're doing the crab view. This baby is a few days old. His PVR has dropped. He's already over circulating. You can see that the Nyquist is high. And I can still visualize my 4 veins. So that's a sign that's probably there's a lot of venous flow coming back, right? So you can see there's a vein here, there's a vein here, there's a vein here, there's a vein here. And we can visualize that. You see it here, the vein. We can visualize them at high Nyquist because probably the velocity is it's higher because there's more pulmonary flow. So we saw this, we saw this, we saw this, and then you've seen this already. We can look at the different phases depending on the cardiac cycle. And then you can measure your S and your D waves in these views too. These are mostly adult and pediatric algorithms to describe relaxation anomalies or diastolic dysfunction. They're not necessarily adapted to the newborn. So, we can measure them to get a sense and follow them in time, but they're not necessarily validated in the newborn population as normative value versus abnormal values. So we need more research into that. But I still provided them here as a reference. And that's what you would see if you lose the phasic flow. This is a patient with pulmonary vein stenosis. You can see at high Nyquist, there is like this flow coming from the right lower pulmonary vein and left lower pulmonary vein. And it looks turbulent at very high Nyquist. And when you actually see it, you lose this phasic flow. And if you do a VTI, you can see that the mean gradient is like 7 millimeters of mercury, which is high. It's above 4. 4 and above, you're starting to get concerned that there's like stenosis of your pulmonary veins in the mean gradient. So we're going to finish here. We're going to continue next time, but I hope this was useful.